Welcome. We'll discuss intraocular melanocytic tumors in two sessions. In the next session, we'll take up choroidal and ciliary body melanoma, and the remaining intraocular melanocytic tumors we'll discuss here. Pigmented intraocular tumors can be of two types. The most frequent are the intraocular melanocytic tumors arising from melanocytes or nevus cells present in the vascularized uveal stroma in iris, ciliary body or the choroid, and they range from benign nevus tumors to malignant melanoma. Less commonly, pigmented intraocular tumors can also arise from pigmented epithelium of the iris, ciliary body or the retina, and the pigmented epithelium of these structures also contain melanin granules. Iris freckles are benign lesions which appear flat and pigmented and are usually multiple. They do not distort the stromal architecture and consists of increase in the amount of melanin in the melanocytes without an increase in the number of the melanocytes. So they are not considered as a tumor and they are more prevalent in elderly individuals. They are associated with ultraviolet exposure and an increased risk of cutaneous melanoma. Uveal nevus consists of increased number of nevus cells. Nevus cells are a variant of melanocytes but are larger, rounder and without dendrites. Uveal nevus is considered to be the most common primary intraocular neoplasm in humans, and almost all uveal nevi have mutations in either GNAQ or GNA11 genetic loci, which are considered to be the initial step towards malignant transformation. But mutations in these two loci by themselves do not cause malignancy. Uveal nevus can be iris nevus, ciliary body nevus or choroidal nevus. Iris nevus appear as benign, variably pigmented lesion in the iris stroma, and they are stable in size on long-term follow-up. They are usually less than 3 mm in largest basal diameter and less than 0.5 mm in thickness or elevation. Iris nevus can be circumscribed, involving a discrete region of the iris, or diffuse, involving an entire sector of the iris, as seen here in this photograph. It can be flat, as seen here, or nodular, and it can be single, as seen here in this photograph, or multiple. In contrast to iris melanomas, iris nevi do not cause distortion of the iris architecture, do not cause pigment dispersion or secondary glaucoma, do not have satellite lesions, and do not have prominent internal blood vessels. Larger iris nevi can cause ectropion UV and or sectoral cataracts, and ectropion UV or sectoral cataract are not considered as differentiating features of iris melanoma from iris nevi. Iris nevi require management by serial slit lamp photographic documentation to document growth of the lesion, and serial gonioscopy to rule out a ciliary body tumor and to document extent and progress of angle involvement. Choroidal nevi occur in up to 8% of the population, and they are usually asymptomatic and detected incidentally. However, they may affect vision if they are located in the macular area due to degeneration of the overlying retina and the retinal pigment epithelium. Choroidal nevi may be static or they may grow very slowly, usually in younger patients, and the rate of growth is said to be less than 0.1 mm per year. They are flat to minimally elevated lesions, typically less than 5 mm in largest basal diameter and less than 1 mm in maximal thickness. The pigmentation appears homogeneous and can vary from brown to grey to amelanotic, and their margins appear soft and indistinct. Features suggesting long-standing benign nature of a choroidal melanocytic lesion include drusen's on the surface of the lesion and RPE changes on the surface of the lesion. The RPE changes can be in the form of pigment clumps or in the form of whitish areas of fibrous metaplasia of the retinal pigment epithelium. Sometimes a yellowish-orange discoloration can be seen around the margin of the lesion, and this also suggests a benign nature of the tumor, and this is called a halo nevus. These two signs are very important to remember as signs suggesting benign nature of a choroidal melanocytic tumor. Surface features suggesting malignant potential include lipofuscin appearing orange in pigmented nevi and darker in amelanotic nevi, exudative retinal detachment over the lesion and surrounding the lesion, and choroidal neovascularization. These two signs are also very important to remember as signs suggesting malignant potential of a choroidal melanocytic lesion. Diffuse choroidal nevus may occur in congenital ocular or oculodermal melanocytosis, and in these patients there is a 1 in 400 risk of developing ciliary body or choroidal melanoma. B-scan ultrasound of a choroidal nevus shows a relatively thin fusiform shape in cross-section, moderate internal reflectivity, and tapered ends of the fusiform shape blending with the normal choroid. Management of choroidal nevus includes photographic documentation, USG measurement of tumor thickness, OCT to detect subretinal fluid, and lifelong regular follow-up to detect malignant change. Melanocytomas or magnocellular nevi are rare tumors made up of large polyhedral nevus cells with abundant cytoplasm containing large melanin granules. Iris, ciliary body, and choroidal melanocytomas appear as elevated pigmented lesions resembling nevus or melanoma and are difficult to differentiate from them. Melanocytomas of the iris may seed anterior chamber, resulting in glaucoma. Ciliary body melanocytomas are usually not visible but may extend through scleral emissary canals and appear on the outer surface of the sclera as a fixed pigmented subconjunctival mass. Melanocytoma of optic disc has a typical appearance and appears as a pigmented lesion adjacent to, covering, or invading the disc with feathery edges. Melanocytomas of optic disc cause swelling of the optic disc and occur more commonly in non-whites. Melanocytomas of optic disc can grow very slowly but does not show malignant potential. Epithelial tumors of uveal tract and retina can also be pigmented because of the presence of melanin granules in these epithelia and thus can mimic uveal melanocytic tumors. Adenoma of these epithelial layers are very rare tumors. Adenoma of pigmented epithelia of the ciliary body are black in color and may appear similar to ciliary body melanomas. Adenoma of non-pigmented epithelia of the ciliary body appear white in color and may resemble an amelanotic ciliary body melanoma. Adenoma of the iris pigment epithelium appears as a black nodular tumor gradually replacing the overlying iris stroma, and adenoma of the retinal pigment epithelium appears as an oval nodular and deeply pigmented tumor in the fundus. Adenomas rarely grow or undergo malignant change, and adenomas show a high internal reflectivity on ultrasound. Adenocarcinomas of these epithelial layers are extremely rare tumors. Adenocarcinoma appears similar to adenomas but shows significant growth. Adenocarcinoma of iris and pigmented epithelium of the ciliary body appear black in color, but adenocarcinoma of non-pigmented epithelium of the ciliary body appears white. Adenocarcinomas of retinal pigment epithelium can either arise de novo or from a pre-existing congenital hypertrophy of retinal pigment epithelium, which we will be discussing in a subsequent session. Adenocarcinomas of retinal pigment epithelium appears black and they may show dilated feeder vessels and lipid exudation. Though histologically malignant, risk of extraocular spread or metastasis is minimal, and adenocarcinomas like adenomas show high internal reflectivity on ultrasound. Simple hamartoma of retinal pigmented epithelium are small, less than 1 mm, well demarcated pigmented lesion near the macula, and they do not increase in size. Combined hamartoma of retina and retinal pigment epithelium are congenital lesions with focal disorganized development of retina and retinal pigment epithelium. They are ill-defined, slightly elevated lesions with grey to black pigmentation at their base and with overlying whitish glial tissue and angulated blood vessels within the tumor. They are usually located near the optic disc but may also be peripherally situated, and the pigmentations of this lesion can obscure underlying retinal blood vessels. These lesions can change appearance with time due to contraction of the glial cells within the tumor but rarely enlarges significantly, and they do not have any malignant potential. The vascular component can give rise to exudative retinal detachment and lipid exudation, and combined hamartoma of retina and retinal pigment epithelium has been associated with neurofibromatosis, type 2 neurofibromatosis more than type 1 neurofibromatosis, and other entities. Uveal melanomas can be found in iris, ciliary body, or choroid and arises from a malignant transformation of a previously normal melanocyte or a nevus cell in the uveal tract. Risk factors for the occurrence of uveal melanoma include older age, fair skin, and congenital ocular melanocytosis. We have already mentioned that congenital ocular melanocytosis can occur in non-whites as well as those with fair skin. Genetic factors are now considered to be very important in the causation of uveal melanomas. Dysplastic nevus syndrome is a distinct clinical entity in which patients develop multiple cutaneous melanocytic tumors. Patients with dysplastic nevus syndrome are prone to develop uveal melanomas, and we have discussed dysplastic nevus syndrome in the session on malignant tumors of the eyelid. Mutation in GNAQ or GNA1 genetic locus is considered as a prerequisite before melanoma can develop, but they are not known to prognosticate risk of metastasis in a patient with choroidal melanoma. Monosomy 3 and mutations in the BAP1 gene locus are very important in uveal melanoma because they prognosticate the risk of metastasis in a patient with choroidal melanoma. Although uveal melanoma can spread extrasclerally, hematogenous dissemination is the principal danger, and most melanoma-related deaths are due to liver failure following liver metastasis. In contrast, malignant melanocytic tumors of the skin and mucous membrane can also disseminate through lymphatics. Unlike retinoblastoma, in which more than one-third of all cases have multifocal and/or bilateral tumors, choroidal melanomas are almost universally unilateral and unifocal, and they usually do not have a family history except in families with mutation in the BAP1 gene. Iris melanomas account for up to 5%, that is a small fraction of all uveal melanomas. They are usually pigmented as we see here in this photograph, but can also be amelanotic. 75% of iris melanomas are found in the inferior iris as we see here in this photograph, and smaller iris melanomas can be difficult to differentiate from iris nevus. Patient with an iris melanoma can be asymptomatic or present with a recent onset of a dark or an amelanotic spot on the iris, and this spot is usually focal and nodular but can also be diffuse. Patient may also complain of pain from raised intraocular pressure. Signs suggesting malignancy in an iris lesion include recent onset, rapid growth, intratumoral vascularity, which is easily visible in amelanotic tumors, pigment dispersion, satellite lesions in the iris stroma or in the angle, secondary melanomalytic glaucoma. This occurs due to histiocytes ingesting dispersed pigments from necrotic tumor and then blocking the trabecular meshwork, and extrascleral extension. Other signs which can be present in an iris melanoma but which do not definitively indicate the malignant nature of the tumor include ectropy on uvea and inability of the pupil to dilate in the quadrant of the tumor, secondary cataract, and unilateral hyperchromic heterochromia from involvement of the entire iris. An iridociliary melanoma involves both the ciliary body and the adjacent iris and characteristically demonstrate a furrow in the iris anterior to the anterior border of the tumor. Iridociliary melanomas can also grow circumferentially when they are called ring tumors. Ultrasound biomicroscopy is helpful to determine the size, extent, and the characteristics of the tumor. Anterior segment OCT imaging is not very helpful to image through the pigmented tumor or the pigmented iris. Fine needle aspiration biopsy helps when the diagnosis is unclear clinically. The 8th edition of American Joint Committee on Cancer Staging, or the TNM staging, classifies iris melanoma based on the characteristics of the primary tumor and whether or not lymph node involvement or metastasis is present. The primary tumor is classified as T1 when it is limited to the iris, as T2 when it extends up to the ciliary body and or the choroid, T3 when it extends up to the sclera, and T4 when it extends beyond the sclera to involve the optic nerve or the orbit. Presence of melanoma-lytic glaucoma is considered for subclassifying the primary tumor. Involvement of regional lymph nodes or other parts of the eye are considered in the end staging, and in the M staging, presence and size of the distant metastasis are considered. Grade of the tumor is also considered in TNM staging, and the tumor is graded as either spindle cell tumor or mixed cell tumor or epithelioid cell tumor, with the spindle cell tumor having a better prognosis than the mixed cell tumor, which in turn has a better prognosis than the epithelioid cell tumor. Iris melanoma requires treatment when there is documented growth or when there is secondary glaucoma. The primary modalities of therapy of uveal melanomas, whether iris melanoma or choroidal melanoma, are surgery and radiation therapy. We may note here that chemotherapy, which has been found to be so effective for treatment of retinoblastoma, has not been found to be effective for the primary tumor of uveal melanoma. Surgical treatment of iris melanoma can be by either excision of the tumor or enucleation of the eye containing the tumor. Excision of the tumor is indicated when the tumor appears cohesive without seeding and involves less than one quadrant of the anterior segment, and this can be done either by iridectomy or iridocyclectomy. Enucleation of the eye containing the iris melanoma is indicated when there is anterior chamber seeding in the form of satellite lesions or secondary glaucoma, or the tumor involves more than one quadrant of the anterior segment, or the eye is painful and blind. Radiation therapy is indicated for larger lesions which cannot be resected, and radiation can be administered either by brachytherapy or proton beam irradiation. We'll discuss about brachytherapy and proton beam irradiation in the next session. Iris melanomas have a low mortality rate of 1 to 4%, and risk factors for metastasis include invasion of the anterior chamber angle and secondary glaucoma. To recap, uveal nevi are considered to be the most common intraocular primary neoplasms. Uveal nevi arise from nevus cells. Iris nevi, in contrast to iris melanoma, do not disturb iris architecture, do not cause pigment dispersion or secondary glaucoma, do not have satellite lesions, and do not show prominent intralesional vascularity. Features suggesting benign nature of a choroidal melanocytic lesion include surface drusen, surface RPE changes, orange halo around the nevus, and a very slow growth of the nevus of less than 0.1 mm per year. Features suggesting malignant nature of a choroidal melanocytic lesion include surface liposuction appearing as orange pigment over the tumor, serous retinal detachment, surface choroidal neovascularization, rapid growth usually demonstrable within 1 to 3 months, and diffuse choroidal nevus in association with ocular or oculodermal melanocytosis. Iris melanomas require treatment when growth of the tumor is demonstrated or when there is secondary glaucoma. Iris melanomas are treated either by resection of the tumor, enucleation of the eye, or by radiation therapy in the form of brachytherapy or proton beam radiation. And unlike retinoblastoma, chemotherapy is not effective for the primary tumor in uveal melanoma. Thank you for listening.